Okay, SPECT, image acquisition, processing, and artifacts. Often said that the art of nuclear cardiology is reading through the artifacts, so you need to know how to recognize them and see how they may be formed, corrected before you have a pitfall. The material for this talk is largely taken from this excellent review article in the Journal of Nuclear Medicine Technology called Artifacts and Pitfalls of Myocardial Perfusion Imaging. Also from talks that April Mann, Fellow of the American Society of Nuclear Cardiology, has given. She's from Hartford, Connecticut, and the Technologicalist's Guide to Myocardial Perfusion Imaging, which is freely downloadable from the EANM, European Association of Nuclear Medicine website, which is actually quite a handy, useful document. I mean, what we're really talking about here is high quality imaging, and the processes and steps that are involved in that should be established up front, and it means working out what's best for your department and its workflows and its patients that it sees, and having then established standard operating procedures, everyone should work according to them and follow them. So high quality comes even before the patient arrives in the department, because the machinery, the gamma camera, should undergo quality control procedures, and some of these need to be done daily, some weekly, and some monthly. And the medical physics department will institute those checks and audit them being carried out, such that you know that the camera is working fine. Then it comes to the patient. He's been stressed. He's been injected with a radioactive tracer, and now you need to image him. So the proper positioning of the patient and the setup of the scan is crucial. The patient should be comfortable. They're going to be lying there for some minutes, and if you can keep them comfortable, you can therefore by reduce patient motion artifact, and you can try and address some factors that cause attenuation, stopping of those gamma rays between the patient and the gamma camera, and which cause artifacts. And then once you've acquired the images are processed, and the data needs to be evaluated, assessed, seen where you need to repeat the image acquisition perhaps. Then the data needs to be reorientated and reconstructed so that you've got the traditional images that we report from. So at any stage of this, something untoward may happen, and which could be propagated throughout the scan. So there are many reasons why artifacts and pitfalls may happen during an MPS, and this Venn diagram nicely shows that it could be a combination of the patient factors, equipment factors, and human factors that lead to these artifacts and pitfalls. Common sources of artifacts. First one's to do with patient positioning. Can the patient get their arm be comfortable, lie with their arms above their head, so you don't have their arms on their torso, which will be stopping the gamma rays. And then radius describes the orbiting distance of the gamma camera heads from the patient. They need to be very close to the patient, and if they're further away, then that allows more scatter and fewer cans to hit the camera. The patient themselves may be misshaped for an MPS scan. There might be element of soft tissue attenuation, and here the breast and the tummy can simply get in the way. There may be extra cardiac activity which interferes with the scan. There might be patient motion if they're, for instance, fidgeting, out of breath, uncomfortable, or their heart rate may be irregular, and arrhythmia can cause difficulties and issues with the ECG gating. So really it's key that when the patient is positioned underneath the gamma camera, that they're as comfortable as possible, and also that the patient's position is reproducible between the stress image acquisition and the rest image acquisition, so that everything else is in the same place, so that things are directly comparable. But things can go wrong. This is raw data, planar images from the raw data of a MPS scan. This is the original rest scan, and then the stress scan, and this is a one-day protocol, and the dose should be larger in the stress, but actually the images look very similar, the counts look very similar. Therefore then the stress scan was repeated, and the problem here was actually that the stress injection of radiopharmaceutical had tissued in the arm of the patient, and not much had reached actually inside the heart and the body. Therefore the scan had to be repeated. What is the effect of having that tissued injection on the scan? Well, the original data showed relatively homogeneous uptake throughout the heart on these short axis images, but actually when the scan was repeated, this focal defect anteroseptally was then demonstrated, which was simply not visible due to that loss of signal in the original data. So therefore, this perfusion defect was masked. So, tissuing the injection is fairly easy to spot. The patient will report some pain, possibly, although the volumes injected are small. But you can easily move the gamma camera heads over the arm and see whether there's traces left behind in the arm if that's happened. Trusting that hasn't happened and you acquire the image data, you need to review the raw data. The technologist will select various filters and perform the reconstruction of that data and then reorientate the data along the cardiac axes. This video clip shows essentially what the raw data looks like. There's the heart in the middle of the field of view. We can see the left ventricle and to a lesser extent the right ventricle. You see the liver and this trace is hepatobiliary excreted, and therefore you might see gallbladder excretion, and thereby a tracer might therefore reflux back into the stomach. It has, in this case, the stomach is nice and empty, or pass along the duodenum into the first part of the small bowel. You may get lung uptake, for instance, if you push the patient into heart failure during the stress imaging, which is a poor prognostic sign. And also here you can see the effect of free technotate in the salivary glands. But review of the raw data is a possibility to review for attenuation and to review for patient motion, and also this extracardiac activity and its proximity to the heart, which may all cause problems. So here's an example of some stills from that cine raw data showing that there's an offset between in the left ventricle between the frames, indicating that the patient had a sudden jump in movement. There are motion correction algorithms that can be applied, but you need to recognise this fact before you apply them, and that could maybe stitch the data back together. But again, if we look at this data set, the effect of the motion is seen on the top row of reconstructed images, the short axis. The arrowheads are pointing towards this defect, again, anteroseptally, with this little tail of activity coming around, which is not anatomical. When the images were reacquired and the patient was more settled without motion, that apparent defect has disappeared. It's an artifact, it's not real. I mentioned reviewing the raw data for that extracardiac activity, and here's an example on, again, the raw data saying that there's quite a large hotspot here. This is in the stomach. There's excreted activity in the liver coming into the gallbladder. Hot uptake in the stomach, and the effect of this on the scan is this very close proximity of the heart to the stomach, and the algorithm that contours the borders of the LV has actually included the stomach inside the contour ring, and such that when it automatically calculates the ejection fraction, we have an ejection fraction of 30%. The solution here is time. The patient can be rescanned, possibly fed something to eat, hot chocolate or a fizzy drink, which might help just move things along within the stomach and then get rid of that stomach activity. Now there's a nice gap here between the stomach and the subdiaphragmatic contents, and the contouring of the LV no longer has any problem and is contoured the heart correctly, and now the ejection fraction is in the normal range. So if we review this perfusion scan, we have stress images on the top, rest images on the bottom, short axis and vertical long axis here on the bottom slice. We can see that the arrowheads are pointing to a relative reduction in the anterior wall. If we look at the intensity of the inferior wall compared to the anterior wall, there's a difference, and on stress and rest it looks pretty similar, so a fixed defect in the anterior wall. But if we go back to the raw data, you can see that the arrowheads are pointing to there's this crescent-like reduction across the entire anterior wall of the heart, and that's due to breast attenuation artifact. Large-chested lady, it's a fixed perfusion defect anteriorly, not that of an infarction, but simply soft tissue breast attenuation in this case. So again, knowledge of the size and shape of your patient and review of the raw data will help you avoid miscalling this as a fixed defect here, so a potential subendocardial infarction. Whereas in this patient, there's an anterior reduction on the vertical long axis views, basal and mid segments are reduced, and they seem to improve on the rest images. And we can see that again in the short axis, the arrows are pointing towards this reduction. There's a little bite taken out of the donut, but on the rest images, the donut is whole. However, when you review the raw data, you can see again we have this crescentic reduction across the uptake of the heart. It's there on stress and on rest, but it's in a slightly different position. And this is breast attenuation, but rather the breast had changed position slightly, therefore the attenuation has moved, and therefore the reduction has changed position. So again, knowledge of the patient's size and shape, recognizing that this position change has happened, mean that you won't call this as ischemia, but the changing attenuation artifact. Some more raw data showing the effect of stomach uptake here, hepatobiliary excretion, hot gallbladder, and then stomach uptake within the stomach and coming up behind the stomach because this patient has a hiatus hernia. And these effects can therefore interfere with the image resolution of the inferior wall, as I will show you soon. Now, one step to try and do that is to limit the reconstruction volume. So the technologist will select what goes on in through the data. So we don't take this all of the raw data, but we try and narrow it down to exclude everything else. But this in itself can cause problems due to partial voluming errors and truncation, and can also cause difficulties in display or windowing or intensity scaling if done incorrectly. So this is an example of one of those artifacts, a simply truncation artifact. Those narrow limits have brought in being far too close, and we end up clipping off the apex and part of the inferior wall of the heart. So the technologists are taking that raw data, which is in a in a coronal plane, and reorientating along the long axis of the left ventricle. And by doing that, we determine those traditional standard views of the myocardial perfusion scan along the short axis, the vertical long axis, and the horizontal long axis, but these axes must be reproducible between stress and rest. So this is an example of good reorientation. Here's the long axis of the LV, and that's along which we're centering, such that we can then take slices along it and through it and derive these short axis views, this vertical long axis, and these horizontal long axis views. If that reorientation is off by any way, what does that mean? That means we're no longer comparing like with like along the slices, and we can actually create or hide perfusion defects. So this is an egregious case and is easily spotted, and we can go back to the technologist and say, can you please reorientate this correctly such that we're looking like with like. So here's an example. You can see that the axes are off here. It's not going straight down the apex of the ventricle. It's corrected subsequently, but when you look at the images, there's now an apparent lateral defect which improves, but that's simply because we're not comparing the same slice on stress and on rest on the orientation. If that gets straightened up, so now both hearts are orientated correctly, that perfusion defect has disappeared, simply because we were looking at off-axis slices. So we discussed breast attenuation artifact. The next thing that often happens is subdiaphragmatic attenuation artifact, and that is due to gentlemen having fairly prominent tummies, and they stop the photons before they hit the gamma camera. So here we have a fixed inferior reduction on stress, no change on rest. And if we knew the patient's waist size, his BMI, and his shape from the raw data, then we can adjudicate this as not an attenuation, not a subendocardial infarction, but as an attenuation artifact. Other clues in to help us determine that would be the regional wall motion on the ECG gating, because an artifact should have hypokinesis, whereas an attenuation should have normal regional wall motion. So this is an expected finding, and it's interesting if you then take that same scan and process it according to either sex of the normal databases. On the male database, the computer is smart enough to realise, hang on, I've seen this before in a lot of male cases, and I'm not going to call this as a problem, but as on the female database, it thinks, oh, I don't see this so often, and it now calls that as this blackout area showing areas of change, and it says, well, hang on, maybe there's a problem there. So again, these errors get propagated all the way through and through the processing steps if you're not careful to spot them. This diagram is to remind me to mention now the ramp filter and the ramp filter artifact, and this is just one of the filters we use to reconstruct the data. But the point to notice here is that that actually in areas of high counts you can actually get a negative image in your data. The relevance of that is again with the stomach uptake I mentioned previously. If this is a reconstructed short axis data set, there's a very hot subdiaphragmatic organ here, probably the stomach, and it means that the data and the way the data is reconstructed is that we get a relative reduction of counts immediately adjacent to this very hot uptake. Now, ways around that are to use different processing methods, and these two are elements of iterative reconstruction, which actually you see can actually bring back that inferior wall, such that the artifact is less apparent. But again, as I mentioned, another easy solution without using these more fancy techniques is simply to rescan the patient after delay, possibly with some sort of maneuver like eating hot chocolate or cheese sandwich, a fatty meal, to try and shift that stomach uptake through biliary contraction. But when you've got images that are coned down, such that you don't see the extracardiac activity, and you look at the scan and we see a mild reduction inferiorly, but it's much worse on rest, and there's no real concept of what's going on, but that reversal is the wrong way around. Ischemia, the stress images should look worse, not the rest images. So something would ring a bell here. We can go back and look at that raw data, and we realise that actually on the rest image there's very much more liver uptake, and that's liver uptake that is causing that artifact and that reduction of counts here within the reconstruction of the data on the inferior wall. So that's not some sort of pseudo infarct, it's actually the effect of the increased uptake in the liver on the scan due to that brown filter artifact. The solution here was to repeat that rest scan and shift some of that liver uptake along through normal excretion, and then the apparent change at least is no longer apparent, and therefore this image the scan is now more diagnostic. So our short axis images at stress, and the arrowheads are pointing to a relative reduction in the septum compared to the lateral wall. There's a broad left bundle on this patient's ECG, and subsequent angiogram shows that there's no LAD coronary artery disease. So this is a relative perfusion defect, artifactual due to the left bundle branch block. Now there are many reasons why this is thought to happen, largely due to relative hyperperfusion of the lateral wall and hypoperfusion of the septum due to its delayed contractility due to the desynchrony of having left bundle. It's important to recognise that someone has left bundle branch block and not necessarily to attribute this to ischemia. The key thing to differentiate this from left anterior descending coronary artery disease is that true LAD territory ischemia would have to extend more anterior as well as septally, and you don't have isolated septal perforated disease. Therefore, the anterior wall would have to be taken out in a LAD territory lesion causing ischemia. So if it's isolated septal perfusion and you see the ECG and it's got left bundle, then you can say that attribute that to an infarct and not fall into the pitfall. Again, staying with the septum, the other condition also probably quite common is hypertrophic cardiomyopathy, and the relative hypertrophy of the septum causes a relative hotspot compared to the rest of the heart. You can see the difference here in the uptake between the septum and the lateral wall, and it might cause adjacent relative reductions due to that relative hotspot. But you can recognise the morphology and identify that for simply there's more muscle mass, therefore there's more myocytes, therefore there's more uptake from the perfusion tracer. This is a crudely taken video, and I'll just let that play a couple of seconds while you establish what's going on. That's right, the patient's heart and liver are swapped around. This patient has got dextrocardia, in fact, with situs inversus, and has undergone a perfusion scan. And if you don't realise that to be the case when you set up the patient inside the scanner, the orientation of the heart will be the wrong way around, easily fixed. You simply turn the patient around. If they were going in head first, you put them in feet first, and obviously you have to remember to switch around the ECG leads to get the ECG gating correct. But if you don't do that, what you might think is, hang on, there's a rather sort of reduction in the lateral wall, no uptake basally, mild reduction towards the mid segments, and it looks fairly fixed, and you might make the pitfall of calling this a basal lateral infarction, when actually that's simply the relative stubbiness of the septum on the wrong side. The septum is membranous towards the base, and therefore there's less muscle there, therefore there's less uptake there, and this is simply a case of dextrocardia with the patient incorrectly positioned underneath the gamma camera. Again, review of the original cine of the raw data shows that, or review of their radiograph, chest radiograph might clue you in. And as I've mentioned, attenuation and its artifacts, one way we get around that is by using CTs in hybrid SPECT CT machines and indeed PET CT machines to attenuate correct. CT is an excellent density map of the human body, and you know what the photons have to pass through if you've done a CT scan, and therefore you can take that data and put it back into the reconstruction of the nuclear data and correct the attenuation errors that might occur from the breast or from the tummy, as I've mentioned. However, that in itself can cause artifacts, and here's an example where the nuclear is not overlaid correctly on the heart, and therefore the resultant data has a lateral anterolateral reduction. But when we shift the nuclear data so it's superimposed correctly fully on the heart, that anterolateral reduction disappears. That was an error caused by misregistration during the attenuation correction process. So again, you would have to review your data, check the level of registration and the superimposition of the nuclear onto the top of the CT scan data to see that had been done correctly. So, I've shown that there's some steps due to in the acquisition and processing of a myocardial perfusion SPECT, and there needs to be attention to detail at every step, otherwise errors can be incurred and these will propagate throughout the rest of the scan. It's essential to understand these technical aspects to avoid these errors, and hopefully you can see that some aspects of the patient, some aspects of the equipment that you use and how image processing can lead to artifacts and pitfalls. But if you're forewarned, you'll be the wiser. Thank you very much.